Hello, everybody. My name is Cesare Hassan from Milan, and let me thank Lix and Sobed for this important webinar and this important topic. I will reconnect a bit with the concept that had been exposed in the first slide, because at the end, equity and AI are about quality and cancer prevention. As we already stressed in this webinar, we must differentiate the intrinsic goodness of the artificial intelligence with its effect on endoscopy. To have a good AI does not necessarily translate in a higher or more equal quality of endoscopy. And this means that if the original pre-I situation is quite a disaster with a huge variability, we are not necessarily confident that AI will reduce this heterogeneity, introducing more equity in our care delivered. Of course, the first news is a good one, because by increasing the non-methylation rate by 20%, we may expect that all endoscopists will increase their ADR by 20%, so low detector become high detector, and high detector become very high detector. But we are not totally confident on it. First, we need to differentiate between equity and equality. Equity is when I take a low detector and by using AI, I artificially lift him to become a high detector. But as soon as I remove AI, he will become a low detector again. In this case, I'm helping him, but I'm not removing his original gap. On the other hand, equality is when AI help him not only to improve, but also to consolidate such improvement when removing artificial intelligence. This is equality, when AI help all of us to become the same. At this point, we don't have clear evidence if AI brings equity or equality, but what is good, and this may help for the future discussion, is that AI has a larger effect in low detectors than in high detectors. This is exactly what we needed from AI, because this means to bring at least more equity, but maybe more equality in AI. However, when we measure the overall effect of AI outside the randomized trial, we realize that the overskilling leading to equity is not necessarily the usual effect, because there may be the skilling or there may be never skilling. The skilling was first shown in this Polish data. These were endoscopists with quite good ADR before AI. By using AI, they further improved experiencing an overskilling, leading to more equity. But when AI was removed, the initial ADR was actually reduced by 30%, bringing to inequality in the effect of AI. Not only a training curve was not present, but the skilling curve was observed. In addition, we cannot exclude inequity. Inequity is when high detectors get more effect from AI, and the gap with the low detector further improves. In a Japanese study, where AI was given for 2, 3 years, when AI was removed, high detectors actually further improved while low detector did not. Thus, a long exposure to AI can bring inequity in between low detectors and high detectors. I told you before that in randomized trial, AI help more low detectors, but in a long observational Japanese study, actually it was the opposite because the effect of AI was more on experience endoscopy. But let's abandon for a moment the perspective of endoscopy and let's focus on the perspective of a patient. Of course, patients are worried not about the adenoma detection rate, but about the adenoma miss rate, the fact that we miss one every four polyp and one every 10 advanced polyp. However, when we look at it from a patient perspective, and we translated it in actual cancer prevention, the effect was very much limited because every 10 years there were 11 prevented colorectal cancer across 10,000 patients, corresponding to a number needed to treat of 900. So you need to scope 900 patients with AI in order to prevent one cancer. But on the other hand, this was offset by much more surveillance. And this is what patients dislike the most. Indeed, when we translated this in our guideline, patients were really against AI. When looking at it from a patient perspective, inequity and inequality are at risk. Inequity is a risk because not all health system can afford artificial intelligence. And even if a health system can afford artificial intelligence, not necessarily this would go to the patient who need it the most. For instance, a lot of private health insurance do not have a FIT program, excluding these patients from AI. The risk of inequality is when AI is available, but endoscopy do not use or have the skilling or the software is not good and there is automation bias or they are even more distracted. So AI should, in theory, reduce the miss rate and make patients happy, but this could be the opposite. The opposite. When we looked at the patient perspective, especially in the BMJ rapid rec, the doubt on the excess of surveillance gave a recommendation against artificial intelligence, while the ESGE gave a recommendation in favor. The AGA gave first a recommendation in favor and then it downgraded to no recommendation. So you may see how patients perceive the inequality of AI quite sensibly. And the inequality is quite clear when we compare the randomized trial with the effectiveness studies, where the effect of AI is reduced by 50%, mostly because endoscopists fail to switch on the AI device. For this reason, what we need are larger effectiveness study that tell us what happened in real life, possibly in a randomized cluster fashion. Probably we do not have yet such a good study, and definitely we do not have with colon cancer as primary endpoint. For this reason, there is still a lot to do in terms of AI in order to improve quality, but not to give inequality. I guess that the most important point is to confirm that low detector gain the most. from artificial intelligence and that they do not suffer from the skilling. But also real life large effectiveness trial are needed in order to be confident that AI will improve the quality, reducing the inequality. Lastly, we should not forget that AI is not everything. There are a lot of other interventions that reduce inequality in the field of endoscopy, like to measure quality, to measure the withdrawal time, and also to consider the burden associated with all of it in terms of surveillance, in terms of pain, in terms of additional sedation for the patient. So I feel that equity inequality in endoscopy with AI is still open to debate, and all of this eh, unexpected controversy about the skilling invite us to a more balanced and a less enthusiastic approach for AI in endoscopy. Thanks again, Leaks, for such an important webinar, and looking forward to the next meeting. Bye bye.